Good afternoon, ladies and gentlemen. My name is Abbas Zaidi, and I'm one of the former CRY Research Fellows. I'd like to start by thanking the organisers for inviting me here to talk about the echocardiographic assessment of the athlete's heart, and that's particular Prof. Sharma and Dr. Papadakis. Thank you. So, over the next 25 minutes or so, I'm going to briefly recap about the causes of sudden cardiac death in athletes. I'm going to talk about the physiological changes that occur in the athlete's heart in response to regular training. I'm going to talk briefly about the role of echo in detecting things like congenital heart disease. And most of the talk will focus on the role of echo in detecting cardiomyopathies in athletes. We'll talk about left-sided cardiomyopathies, right-sided cardiomyopathies, and I'll finish by returning to the title of the talk, which is the proposed protocol. So we've heard from Professor Sharma this morning about the causes of sudden cardiac death in athletes. And we can see that a large proportion of these should, in theory, be amenable to detection by echocardiography. We have things like hypertrophic cardiomyopathy, we have coronary artery anomalies, infective and infiltrative causes, other cardiomyopathies, congenital heart diseases, and things that can lead to aortic rupture like mitral valve prolapse. That was American data. Our own data from the UK is fairly similar. We have a higher proportion of deaths due to ARVC, which is more in line with the Italian data. But once again, you can see that most of these should, in theory, be detectable by echocardiography. So this sounds very straightforward. And in some cases it may be. We can fairly easily diagnose some things with echocardiography. Things like this, an ASD or PFO. We can see things like coarctation of the aorta. We can get excellent parasternal windows in most athletes, and so we can see the origins of the coronary arteries in most cases. And we can look for things like a patent ductus arteriosus. When we come on to cardiomyopathy, there may be cases who present like this. This is what I call barn door or very florid cardiomyopathy, where you can see gross and abnormal thickening of the left ventricle. However, the problem is that most athletes with cardiomyopathy don't present with such florid disease. They present with phenotypically mild disease. And to compound the difficulty, athletes demonstrate physiological changes that can make healthy athletes look as though they've got a cardiomyopathy. We've seen already from talks yesterday that athletes sometimes can have bizarre ECGs like this. And we see this as well on the echocardiogram. Look at this athlete, a 30-year-old Olympic rower, and you can see that there is mild left ventricular hypertrophy and there is enlargement of all four chambers of the heart. Therefore, a common dilemma faced by the sports cardiologist is the athlete with ECG anomalies and mild structural cardiac remodeling who presents in a grey zone between athlete's heart and cardiomyopathy. And it's essential that we get this right in these grey zone cases, because if we erroneously label a healthy athlete with a cardiomyopathy, then we run the risk of destroying a young and lucrative career. However, more seriously, if we miss a true case of cardiomyopathy, then we run the risk of seeing a sports-related sudden cardiac death. So I'm going to start by talking about the role of echocardiography in the diagnosis of left-sided cardiomyopathies in athletes. And if we come back to the causes of sudden death in athletes, we've seen that throughout the world, the most common cause is hypertrophic cardiomyopathy. Therefore, a large proportion of this talk will focus on athletes with mild left ventricular hypertrophy who are in the grey zone between athlete's heart and hypertrophic cardiomyopathy. Now, the most important thing to ask when we're assessing an athlete with mild left ventricular hypertrophy is this: could this level of left ventricular wall thickening be a normal physiological variant for the unique demographic profile of the athlete in front of me? Because we know that adult athletes have more profound physiological cardiac remodeling. Male athletes have more profound physiological remodeling. Larger athletes and black athletes and endurance athletes exhibit the most profound physiological remodeling. And I'll take you through each of these in turn. Male athletes have more profound physiological cardiac change than female athletes. This is work from more than 20 years ago from Professor Pelliccia in Italy. The chart shows the range of left ventricular wall thicknesses in healthy male adult athletes. And you can see that in the overlap zone with hypertrophic cardiomyopathy, that's an LV wall thickness of 13 millimeters or more, we have around 2% of white male athletes. Then Professor Pelliccia looked at female white athletes. Again, this is the overlap zone where it resembles hypertrophic cardiomyopathy. And we see that none of the healthy adult female athletes that were Caucasian were in this range. So if you see a female Caucasian athlete with a left ventricular wall thickness of 12 millimeters, you should start to think about hypertrophic cardiomyopathy. Adult athletes have more profound physiological cardiac remodeling than younger athletes. This is work from Professor Sharma from 2002. The black bars show LV wall thicknesses in adolescent athletes. That's 18 years or younger. And you can see again the hypertrophic cardiomyopathy overlap zone. Only 0.4% of young athletes were in this overlap zone. So once again, if we see an LV wall thickness of more than 12 millimeters in a young athlete, we should be thinking about hypertrophic cardiomyopathy. Endurance athletes have the largest hearts. Looking back at the work of Palicia from 1991, all of the athletes in his study that had LV wall thicknesses of 13 millimeters or more were exclusively rowers, cyclists, or canoeists. I won't go into this one in detail. Suffice to say that almost every study on physiological remodeling of the athlete's heart has shown that bigger athletes have bigger cavity sizes and they have thicker walls, which is intuitive. And finally, black ethnicity. Now, this is an important one because black athletes comprise a large proportion of elite sports participants around the world. Now, you'll have heard from my colleague Dr. Sheikh yesterday that black athletes can have bizarre ECG patterns. Up to 25% of healthy black athletes may look like this. They can have voltage LVH, convex ST segment elevation, and deep T-wave inversion in the anterior precordial leads. And we see this as well on the echocardiogram. This is work from Sandeep Basavarajaya looking at LV wall thickness in male adult black athletes. White bars are white athletes, black bars are black athletes. And you can see that it's only really the black athletes that had an LV wall thickness of 13, 14, 15, or even 16 millimeters, so that a staggering 18% of healthy adult black athletes will have an LV wall thickness resembling hypertrophic cardiomyopathy. John Rawlins subsequently looked at female black athletes and found that female black athletes also have thicker left ventricular walls than female white athletes. So, for example, if you see a black male with a LV wall thickness of 15 millimeters, it could be a physiological variant, but you would never expect to see that in a white athlete. My colleague Dr. Sheikh extended this work to adolescent black athletes. And again, if we look at the hypertrophic cardiomyopathy overlap zone, we find that around 10% of healthy adolescent black athletes will have an LV wall thickness of above 12 millimeters. So that you could even see an LV wall thickness of 15 millimeters in a 16-year-old black athlete. But if you saw that in a white athlete, it would almost certainly be hypertrophic cardiomyopathy. So what does all of this mean? Well, if we're faced with an athlete with, for example, a 14 millimeter left ventricular wall thickness, and he looks like this, he's adult, he's big, he's black, he's male, and he is a mixed endurance and strength athlete, then it's quite possible that that 14 millimeters is physiological. But if our athlete with a 14 millimeter left ventricular wall thickness looks like this, she's a female, she's young, she is Caucasian, and she is a ping pong player, then we're almost certainly looking at hypertrophic cardiomyopathy. Now, it's not just the left ventricular wall thickness itself that we can use for this differentiation between athlete's heart and HCM. There are a number of other echocardiographic indices. Systolic function is very important. Athletes will tend to have normal or low normal ejection fraction at rest, whereas hypertrophic cardiomyopathy, it may be hyperdynamic. Long axis function is a very sensitive indicator of early subclinical disease in hypertrophic cardiomyopathy, such that tissue Doppler indices of long axis function should be normal in athletes, but may be lowered very early in the disease process in HCM. Here we see tissue Doppler trace showing low velocities in the lateral LV wall. And strain can show normal velocities in healthy athletes, and it may be reduced early in hypertrophic cardiomyopathy, as we see here on the right, low strain rate curve. Diastolic function is another very sensitive indicator of early subclinical hypertrophic cardiomyopathy, so that the E to A ratio in athletes is often high, above 2 sometimes, whereas in hypertrophic cardiomyopathy, it may be low or reversed early in the process. The deceleration time of the E wave is rapid in the compliant ventricle of the athlete, but may be prolonged in the stiff ventricle in HCM. The E deceleration time, the E velocity on tissue Doppler should be high in athletes, sometimes in the region of 20, whereas in hypertrophic cardiomyopathy, it may be reduced very early. So the E to E prime ratio should be low in athletes, maybe elevated in HCM. And a very sensitive index is the ratio of systolic to diastolic flow in the pulmonary vein, which should be low in healthy athletes, but once again may be reversed very early in subclinical hypertrophic cardiomyopathy. Now, I'd like to introduce here the concept of the relative wall thickness. Here we see two athletes, both with left ventricular wall thicknesses of 13.5 millimeters. Now, our athlete on the left has a cavity size of 40 millimeters, and the athlete on the right has a cavity size of 56 millimeters. Now, the relative wall thickness is calculated by adding the left ventricular septal thickness in diastole to the posterior wall and dividing by the left ventricular cavity size. And it's been shown that if the relative wall thickness is more than 0.45, it is suggestive of pathological left ventricular hypertrophy. So our athlete on the left had a relative wall thickness of 0.68 and turned out to have hypertrophic cardiomyopathy on further testing. Whereas our athlete on the right, with a big cavity and thick walls, had a relative wall thickness of 0.45 and was subsequently proven to have physiological remodeling. We can also look at the morphology of the remodeling to help with the differentiation. Here we see a typical athlete's heart. There is symmetrical remodeling in a homogeneous pattern throughout the heart. This is contrasted with what you might see in some cases of hypertrophic cardiomyopathy. We can see things like bizarre patterns of hypertrophy, including apical and asymmetric thickening. We can see systolic anterior motion of the mitral valve, left ventricular outflow tract obstruction, abnormal papillary muscles and mitral valve defects, and gross dilatation of the left atrium. Here we have some examples of apical thickening in hypertrophic cardiomyopathy, and here in these stills show asymmetric septal hypertrophy. Exercise echo is another tool that we can use because we know that up to 70% of hypertrophic cardiomyopathy patients will develop left ventricular outflow tract obstruction on exertion. This, coupled with things like ST segment changes, ventricular arrhythmias, abnormal blood pressure responses, and cardiovascular symptoms mean that exercise is a very powerful tool. And a final tool in the echocardiographic armory for differentiating physiological from pathological LVH is detraining. We may have an athlete, as you see here, with some T-wave inversion and mild left ventricular hypertrophy, athlete's heart or HCM. If we can convince him to detrain for 4 to 6 weeks, we might get some interesting information. Usually, this requires a musculoskeletal injury because athletes don't like to detrain. But we may see that when he comes back after 6 weeks, the ECG changes have resolved and the left ventricular hypertrophy has regressed, which is suggestive of physiological remodeling. Now, the next left-sided cardiomyopathy is dilated cardiomyopathy. We often see athletes with a large left ventricle and a low ejection fraction, and the question arises, could this be DCM? I'm not going to go into this further because you'll be hearing about this in detail from Professor Corrado, the next speaker. Athlete's heart and non-compaction. Again, I won't go into this in detail because you'll have heard a lot about this from Dr. Gatti yesterday. For those of you that weren't here yesterday, this is some work from our colleague Dr. Gatti. Now, this is just a picture of left ventricular non-compaction. This shows, on echo, we can see an increased layer of spongy trabeculated myocardium compared to the layer of smooth myocardium. And we can use things like colour flow Doppler to show blood flow in and out of the intratrabecular recesses. Now, Dr. Gatti's research of over 1,000 healthy athletes showed that left ventricular trabeculation was present in almost a fifth of healthy athletes compared to 7% of controls. And, as we've seen with other things, trabeculation was more common in black compared to white athletes. Now, I'm going to move on to right-sided cardiomyopathies, because this is my particular field of research interest. Again, I'm going to try not to duplicate what you're going to be hearing from Professor Corrado. So I'm going to focus more on what the normal limits of right ventricular size should be in athletes. Now, the main differential is arrhythmogenic right ventricular cardiomyopathy. This is a fibrofatty disorder of the right ventricle with T-wave inversion in the anterior precordial leads, progressive dilatation of the right ventricle, a tendency to ventricular arrhythmias, and in the worst case scenario, sudden cardiac death. Now, it would be easy for us if athletes with ARVC presented like this. This is, again, what I'd call barn door or very obvious ARVC. there is gross dilatation of the right ventricular outflow tract on the image on the left, and the still here shows a very abnormal looking right ventricle with wall motion abnormalities and aneurysms. Now, unfortunately, most athletes will look more like this. You can see a non-athlete for comparison on the left, and on the right, we can see the heart of an Olympic cyclist. You can see that there is enlargement of all 4 chambers of the heart, including a very large right ventricle. So, as we've seen for the left ventricle, before we can say that something is too big, we need to establish what a normal-sized ventricle is for an athlete. Unfortunately, research into the athlete's right ventricle has been neglected historically, in large part due to the highly irregular structure of this ventricle. So, the recommended images on echocardiography are these in the parasternal short axis view, the right ventricular outflow tract above the aortic valve, and just proximal to the pulmonary valve. And in the apical view, RVD1, the basal diameter, RVD2, the midventricular diameter, and RVD3, the base to apex length. Now, it wasn't until 2011 that the first large-scale echo study of right ventricular remodeling in athletes was published by D'Andrea et al. And they published reference values for male and female athletes for the right ventricle. Now, let's see what happens when we compare D'Andrea's reference values with the ESC reference limits at the time. Now, the ESC reference limits suggested that the right ventricular basal diameter in the apical view should be no more than 28 millimeters. And D'Andrea found that his male athletes had RV basal diameters of up to 45 millimeters. So clearly, reference values derived from non-athletes are of no use for the right ventricle in athletes. Now, this was an important study, but it was limited by being restricted entirely to Caucasian athletes. Now, we've already seen that black athletes get more bizarre ECGs than white athletes. They get thicker left ventricular walls than white athletes. They get more hypertrabeculation than white athletes. So the question that naturally arose is, do black athletes get more right ventricular remodeling than white athletes? This led us to perform the following study of physiological right ventricular adaptation in elite black athletes. We assessed 675 elite athletes, 300 of whom were black, and these are some of our findings. This chart shows the range of values for the right ventricular outflow tract in the parasternal long axis view. And we found that up to around 50% of healthy athletes have an enlarged right ventricular outflow tract, regardless of their ethnicity. 51% of black athletes and 2/3 of white athletes had dilatation of the right ventricle in the range compatible with a minor diagnostic criterion for ARVC. 28% of black athletes and 40% of white athletes had marked dilatation of the right ventricle in the range compatible with a major diagnostic criterion for ARVC. When we looked at the determinants of a large right ventricle in athletes, we found similar things to that found in the left ventricle. Male athletes had larger right ventricles. Larger athletes have larger right ventricles. Endurance athletes have larger right ventricles. And importantly, athletes with a big left ventricle have a big right ventricle, which suggests that there is physiological symmetrical remodeling of both sides of the heart in athletes, in contrast to the primarily right ventricular remodeling you'd expect to see in ARVC in most cases. And we published reference values for athletes for males and females, both absolute and body surface area indexed, and we don't think you need ethnicity-specific RV reference values for athletes. However, when we come back to the overlap zone between athlete's heart and ARVC, and we're talking particularly about athletes with anterior T-wave inversion and marked dilatation of the right ventricle, remember that very few white athletes have anterior T-wave inversion, so the overlap zone was only 0.3% in white athletes. But because so many black athletes have anterior T-wave inversion, up to 25%, the diagnostic overlap was 3% in black athletes who had T-wave inversion and a very big right ventricle. So you are 10 times more likely to get the diagnosis or misdiagnose ARVC in a healthy black athlete compared to a white athlete. We've also looked at right ventricular wall thickness in healthy athletes, and we found similar determinants to those found in other parts of the heart. Large athletes get thicker right ventricular walls, male athletes get larger right ventricular wall thickness, and those with large left ventricular sizes and large right ventricular cavity will have a thicker right ventricular wall. So if you're an athlete and you're male, you shouldn't have an RV wall thickness over 7 millimeters, and if you're female, not more than 6 millimeters. Now, I'm not going to go into detail about right ventricular function because you'll be hearing a detailed talk from Professor Corrado shortly, but the sort of indices that we would suggest you should be measuring when assessing the athlete's right ventricle include TAPSE, right ventricular fractional area change, S prime velocity using tissue Doppler, diastolic indices such as E prime on Doppler, tissue Doppler, and assessing the right ventricular wall motion abnormalities, and in some cases, strain can also be useful, and I'll leave that for now for Professor Corrado. Now, we've incorporated this information into guidelines for the echocardiographic assessment of the right heart with particular reference to arrhythmogenic right ventricular cardiomyopathy, and these are accessible on the British Society of Echocardiography website. Now, I'll return to the title of the talk, which is the proposed protocol for echo assessment of the athlete's heart. Now, this is just to finish the talk. Quick history lesson. This is the CRI echo screening form that was in use up until 2010. Now, I'll draw your attention to the fact that it was designed in 1997, and it is very much focused on the diagnosis of hypertrophic cardiomyopathy. We've got fields such as mid-systolic closure of the aortic valve, systolic anterior motion of the mitral valve, pattern of left ventricular hypertrophy, interventricular turbulence. There is some mention of the right ventricle, and that's only the right ventricular wall thickness, presumably looking for right ventricular involvement in hypertrophic cardiomyopathy. Now, this is a long time ago, 1997, so there is no mention of right ventricular cavity dimensions, and there's no use of tissue Doppler because it wasn't really around at that time. So one of the tasks we had was to update the CRI echo form to bring it in line with developments in sports cardiology and in developments in echocardiography. Now, it took about 6 months of successive iterations to the form, and importantly, negotiations with the sonographers about what was feasible in a 20-minute echocardiography slot. And we eventually came up with this, and this form largely encapsulates what I've been talking about in this talk. So for the left ventricle, we've kept important fields, such as assessment of left ventricular wall thickness at 8 different points at 2 different levels. But we've added things like tissue Doppler assessment of left ventricular function. We've added things like assessment of the coronary ostia and descending aortic velocity to look for aortic coarctation. And the right ventricle comes in here. You can see the form is fairly RV heavy. 2 reasons for that. One, my own research is about the right ventricle, so it was a good way for me to gather my data. And secondly, and more importantly, because echo assessment of the right ventricle is so much more complicated than assessment of the left ventricle. So we've added all the right ventricular dimensional indices, including right atrial area, that we've discussed. We've added some illustrations to show where these measurements should be taken. We've added various indices of function and systolic, diastolic function, including tissue Doppler, and assessment of the pressures in the pulmonary artery and in the right atrium. We've incorporated these findings, these recommendations into this document, which was published with CRI in collaboration with the British Society of Echocardiography, which is a guideline for the echo assessment of sports participants. Again, this can be found on the BSc website, and it includes algorithms, including, as I say, things that have been discussed today, assessment of the left heart and assessment of the right heart by echo in athletes. So just to conclude, it is vital to correctly diagnose pathology in athletes, but there is significant overlap between physiology and pathology. Athlete's heart versus cardiomyopathy is a common dilemma in sports cardiology, particularly so in black athletes. Well, and the role of echo, we can diagnose things like congenital heart disease and what I'd call barn door cardiomyopathy, but the bulk of our work is looking for subtle, phenotypically mild disease. We must always note what the normal dimensions are for the unique demographics of that athlete. We can look at morphological characteristics, systolic function, including novel techniques like strain, diastolic function, which is very sensitive, and most importantly, to integrate the echo findings with the overall clinical picture, especially the 12-lead ECG. Thank you very much for your attention. I'll be happy to take any questions.